Good afternoon, everyone. Welcome to the immunization in the context of long-term conditions, led by Nora. Nora, I'll let you introduce yourself if you want.
Thanks, everyone. My name is Nora Rao, and I'm the lead nurse for practice nursing across Barking, Dagenham, Havering and Redbridge, and I'm the clinical lead for nursing with our local training hub, or CPEN. Thanks very much for joining us, and I'm very pleased to be here. I'm very pleased to support the long-term conditions educational program that the training hub has been running over the past couple of months, and this is really just a quick tour of immunisation in the context of those long-term conditions. So it's great to see you all, and Yasmina, shall I hand over to you for any housekeeping?
Thank you very much. Just so that everybody is aware, we will have some time for questions at the very end. So if you wish, you could make note of them and ask them at the end. And just before you all leave, please do take a moment to do the feedback survey. It's very important for us to understand what has and hasn't worked and how we can improve, but also just to get your general takeaway from the session. And upon completion of the survey, you'll get a certificate of attendance. Thank you.
Oh, sorry, I'm very trigger happy with my mouse and not very good at this. So just to let you know, this is not an immunisation update. So this is really, and we make clear the learning outcomes. And so it is really just a discussion and thoughts around what we need to be thinking about, maybe looking at the schedule, the vaccines that we need to think about, factors that might influence decision-making and how we would be able to support that. And then a bit at the end really around vaccine storage, because I felt that's important. For many of you, it will be bread and butter. You do it all every day, and you know exactly what it is, but it's always good to recap, especially when we're thinking about using resources and making sure that things aren't damaged and that what we are giving is in the best condition that it needs to be. So apologies if anyone was expecting anything else, and feel free to leave if this is not what you were thinking it was going to be, but I'd love if you'd stay and just listen to what we have to say and think about any of the other programs or any of the other webinars that you've attended around long-term conditions and how this may link in so across the patient pathway as we're going through. So it would be very remiss of me if I didn't include this lovely slide from Public Health England, which basically is the history of all the vaccines. And I find it really, really useful, even to keep on my desktop, because we all forget. I've been in practice nursing for more than 20 years, and I still think that pneumococcal, we haven't been doing it for that long. It's only a few years. And so if we look back here, it's year 2000 was when we started flu vaccines for over 65. So that's 24 years or 23 years of giving it in a huge program. So that's very reassuring, I think, when you look back. And the same will be the other key number in, or key year in there is, I need to keep my hand away from my mouse. The other key year in there is the pneumococcal in 2004 and the shingles in 2013, although obviously shingles has had a bit of a revamp that we'll discuss as we go along. So really, really useful to sort of realize that we've been doing this for quite a long time. The other thing that, again, you'll always find in any vaccination, immunisation and vaccination educational session is that vaccination saves lives. This is the key take-home message. After clean water, vaccination is the most effective public health intervention in the world. So you will always find that in anything to do with vaccination. So these are the vaccines that we are going to be talking about today, because in the context of long-term conditions, these are the ones that we really need to think about. So you'll all be very familiar, I'm sure, with all of these, and the flu program is obviously our annual program from September, October until the end of March. And apart from last year, you'll know that you started when we got our vaccine in, and then last year, for whatever reason, there were very specific dates, but it all got sorted out. So let's wait and see what's happening this year. But around that time of the year, from when you get your vaccine until the end of March. Pneumococcal, this is year round, and it is available all year round, and we would encourage people to take it if and when they fall into the category of eligibility, or if they haven't had it and there's an opportunistic appointment or an opportunity for you to vaccinate somebody that may have not been so keen and are suddenly thinking about having it done. And the same for the shingles. So again, it's a targeted group once in a lifetime, although you will be familiar that the new Shingrix is a 2-schedule dose. So those are really the vaccines that we need to consider in the context of long-term conditions. Now, it's probably a good time to think about, although it's not necessarily long-term conditions, is the other thing that we're facing at the moment, which is the resurgence of measles in the area and our MMR catch-up program. Whilst I'm not really going to go into it, there will be some of the thoughts and some of the ideas around how to address say vaccine hesitancy, and some of the principles of having vaccine conversations that will apply to that as well. So for anyone that is involved in that, you would be able to sort of take this as a recap of what you might be able to do, because again, it's a very important factor in the health of our young children, or indeed lots of the older people as well, but particularly young children over the next year or so while we get on with this MMR uptake. So the flu vaccination is this poster, and apologies, I found it and then realized that it's actually American, but the principle is the same. So if you have a flu vaccination, it reduces the spread of flu amongst your staff and any people that you care for, and it helps to keep care services running and reduce the burden of the NHS on the NHS over the winter. So it reduces the risk of catching the flu in the first place. It doesn't completely negate it. It's still possible to catch it, but it lowers the risk. It reduces the severity of the flu even if you do catch it, and it reduces time lost through that. And so anyone that is eligible, or their parents or carers, that brief intervention, just that very short message, is enough sometimes to tell them that they're eligible, that they can have it, that it's free, and explain it in very simple language as to what it might, as to what and how it would benefit them. The eligibility for the flu criteria is, we've just talked about it being an annual program. For all of you that have been delivering it, you will know this off by heart. There are some minor changes year on year where there's another group added, and I'm thinking of the morbidly obese there, which was added a couple of years ago. And then children, obviously, that sort of rolling program of the different age groups. But there is a lot of education and a lot of promotion around what those changes are, and available for everyone. So at the beginning of the flu season, you will have your flu update, and you will have the annual letters and lots of information that will make sure that you're kept up to date with that. The importance of this is that, of remembering this, is that for people in those at-risk groups, such as the older people, and any of those with the underlying health condition, flu can be and is a serious disease and can cause death. So that's our take-home message for anyone. And getting the vaccine means that they're less likely to get it, and they're less likely to spread it. And so therefore we can all help to protect everyone that is around us. That's us as staff, anyone that we care for, and our patients, anyone that may be in contact with them, or they may be looking after, or having to visit people that are a bit immunocompromised or unwell. So again, that's our take-home message for those that are eligible on a regular basis, just that short message. The features, what does it feel like to have flu? Well, for anyone that hasn't had it, it's not very nice. It is more than a little cold. It is more than a bad cold. people will talk about, and there've been several instances where I've heard people speak where they've had flu themselves, and they talk about that, similar to when people got COVID, actually, was being hit by a bus, remembering where they were, remembering what they were doing, remembering feeling so unwell that they thought they wouldn't be able to get home. Now, that does seem a bit extreme, but it is actually the case. That's what they say. And that's what it felt like, I have to say. I can still remember many years ago having a flu and feeling really, really unwell with it. And I don't think I've had one since. Around the incubation period, again, for us as staff, we need to think about the incubation period when the virus, before the virus is shedding, or as the virus is shedding, and before the symptoms appear. We don't actually know. You don't know that it is that you've got flu, and so you're completely asymptomatic, and then you shed the virus and you become symptomatic. That's where you have all the symptoms. So it's really quite difficult to know when you've got it and when you may be sort of passing it on to anyone else around. So again, another reason why, if we can prevent it, just a good enough excuse really for making sure that we are protected and we protect anyone that we can. Complications, again, you'll be able to read here and you'll be familiar with all of those, but always the list starts low and death is the ultimate. And again, this is with these, so you can have many of them, but eventually for some people, unfortunately, they will succumb. And so it is really quite a serious illness, and we have the ability to protect people against it. So what information do people need to know to make an informed choice about having that? So there's a list here. You'll be able to, it's some of the stuff that we've just talked about. Having the vaccine is the best way to protect yourself and anyone else from catching it. You should get it as soon as it's available, and we've talked about the time that it is, the September, October. It is serious. We've talked about, you know, people that can die from it, and there are a number of deaths every year, and I've forgotten how many, but you'll be able to look that up. Each year, how many people die from flu. It will vary with how effective the vaccine is, what the protection is within it. It will vary on the uptake, and it will vary on underlying conditions that people will have. So these are all the things that we would need to be able to discuss fairly quickly with people to give them that information that they need to make an informed decision as to whether to have it or not. So moving on from the flu, pneumococcal is the other one that we've talked about. And again, it will be a very similar group. Pneumococcal, serious illnesses like pneumonia and meningitis. And again, a number of people will die from this every year. It helps protect against those bacterial illnesses, and who should have it. So basically, it's recommended for babies, and I think this is a key thing that we need to try and get across when we are trying to encourage people to have pneumococcal. We very much focus on the over 65s, which we know that particular preparation of that vaccine is for them, but actually all babies are being immunized against pneumonia. And so that helps in some ways to normalize it and to get people to accept that actually it is a vaccine that is safe, it's a vaccine that can help them, and that we're all at risk of getting seriously unwell if we develop pneumococcal disease. The eligibility, again, is very similar to all the others. There are some extra ones in here, so it's all the chronic diseases, as well as the asplenia here and immunosuppression due to disease or treatment. So these are key things. Our computer systems are really very clever now and are updating patients' records, and we will get these prompts as we go along. So there's a very good reason for these prompts, which is basically for us to identify these people, but also to be able to offer them the vaccine at the earliest possibility. And it is also, sorry, I've lost my train of thought now for a second. Oh gosh. It is also, the reasons why are very similar to the flu group that we were just talking about. So shingles, moving on to shingles infection, which was the other vaccine, the third one that we're talking about. The shingles infection is, and I've jumped on a bit. No. Shingles infection is a viral rash, and it is very painful, and it is from the herpes zoster, or the chickenpox virus, which generally most of us are exposed to at a younger age, and then that lays dormant in the nerve ending and is revitalized or becomes infectious again in times, particularly around age and in times of stress. There are any number of reasons that people can get this, and it can occur at any time. It increases with age, and it's particularly dangerous for people who are immunocompromised. So a lot of confusion around shingles at the moment. We had our Zostavax vaccine, and again, if we go back to, I talked about 2013, so we've been offering that now for 11 years, but at 10 years in September last year, the vaccine went over from Zostavax to Shingrix. The benefit of that being that it can be used for immunocompromised people, and given that that group was the most severely affected, should they get shingles, that was really groundbreaking, and that's the group of people that we're particularly focusing on at the moment, around if they are immunocompromised by disease or treatment, that they have that, and they remain, and they can have that from the age of 50 and remain whilst they're immunocompromised. The confusion is, as you'll all be familiar, and I'm sure getting settled into it now, the program that was from 65, so anyone turning 65, but over 70. So it was that in-between period that became very difficult and very complicated, the algorithm that was created. The reason for it apparently was just about demand. If general practice at that time in September was overloaded with having to give everyone shingles, then general practice on its knees, and so we wouldn't have been able to maintain the service. So it really is about sorting out demand, making sure that we're not overloaded. And it wasn't to do with finance or the cost of it, as people were worried, but there may well be something about the amount of vaccine that is needed. So that's the reason why. I'm not going to go into it because it's really quite complex, and a lot of these have to be taken on an individual basis, and there is lots of information available for healthcare professionals when they're explaining to this, and there is a calculator about, you know, when your time, when it is you, but basically it's if you're turning 65 and then over 70, and then it will roll on each year, you will go closer to 70, in which case you'll be able to have it. So the main problem with shingles is that obviously it's very painful, and whilst it's lasting, it's extremely painful for most people. But the problem with it is the post-herpetic neuralgia, which is that persistent pain that can last for years and years afterwards, and it is really debilitating pain. And so given that we're talking about people as they get older, they may well have other health conditions, and it really does impact on quality of life. So to have this opportunity really to reduce the incidence of that, to reduce somebody getting it, the possibility of somebody getting it, or certainly like the other vaccine, reduce the complications and reduce the severity, even if they are to get it. It's an amazing opportunity, and one that we really do need to try and encourage and offer vaccination to everyone that is eligible. So a key take-home message, if nothing else, is that there are reasons to vaccinate, and this is very non-clinical, it is non-confrontational. Basically, what we're saying to all our patients is that any vaccination will reduce your chance of getting the condition, and it also reduces your chances of getting serious problems if you do get the condition. So for those people that, you know, have existing health conditions, which are the eligibility criteria that we talk about, their chance or their risk of becoming seriously unwell, their current existing problem, which may well be well controlled, can very easily deteriorate and cause huge complications if they were to get the illness. And so, in a nutshell, that is why we are vaccinating people. So we talk about this vaccine acceptance and it being a continuum. And if you look at the syringe here, you will see that there are some people who just refuse everything, and then right over at the other end, there is on the blue end, it is where people will be very happy. Oh yes, you know, that's fine, I'll have anything good that's going. And then you've got that bit in the middle where people sort of are a bit unsure. They sometimes don't want to adopt too quickly. They want to wait and see for a bit longer how everybody else, the general population, are getting on with it, or they will be wary about side effects. So you'll often get, oh, I'll have my flu today because I know that's okay. I've always been all right with it, but I want a delayed pneumonia because I'm, you know, going away or going to a party for the weekend and I don't want to be unwell. So there's a little bit unsure, but with a little bit of coaching and a little bit of information giving, then they will be happy to come along. So that's it's often quite fluid, as you can see, and it will vary between certain vaccines, but people will have questions and they'll want to have a discussion about it, and they will often need that information and then want to come back at a later date when they've had an opportunity to think about it. Of course, we know, working in general practice, they don't always come back, or they don't always find it easy to come back. And so it is possible to, you know, prompt them and to set up a text reminder or something for them to come and have a chat, or certainly opportunistically at each encounter as they come along for whatever, to be able to remind them that this is still available if they would like to have it. And obviously with the flu is during the season, but the other two are year round, so we'll be able to do that. So why is vaccination important? So we've talked about it in the context of it keeps people well, it stops them from getting unwell as individuals. And we've talked about the spread of it, where we want to stop it being spread around to people around us. For us as staff, we don't want to spread it to our patients or to anyone that we look after. But really, looking at the bigger picture, we need that herd immunity, or that community protection. And this isn't going to go into a big immunology lecture or anything, but you'll all be familiar with that herd immunity. We need X% of people that are protected. And the reason for that is we're very unlikely to ever get to 100%, because not everybody will be able to be vaccinated. There will always be somebody in our program, in our community, in our schools, in our areas, who are too unwell to have it. So it lies on the responsibility of everyone else, really, to be vaccinated and then to create that herd immunity, which will keep the vaccine out and keep those people that can't have it safe. The other reason is, again, on a global scale, the World Health Organization have described vaccine hesitancy as one of the 10 key threats. And this was in 2019, and I don't think they've changed. It still is, as far as I could see in all the literature. And that, it seems sort of quite glib, but really when you look at what some of the other 10 threats are, the other of the threats are, they're all the biggies as well. So they're the non-communicable diseases, diabetes, heart disease, a pandemic, influenza pandemic, antimicrobial resistance. These are all the biggies that are concerning the World Health Organization. And so vaccine hesitancy being in there really should make us think about those conversations that we have to encourage people to consider vaccination and to have the information to make an informed consent or an informed decision about what they do. So in short, really, it relies on all of us to support that vaccine confidence and vaccine acceptance. The other thing that it is, why it is important, we talked about vaccine. There are some diseases that have been completely eradicated, and unfortunately, because of that hesitancy, are now making a resurgence. So we talked about the MMR and the cases of measles. Now, I know measles wasn't eradicated, but our numbers were pretty good, and they have dipped significantly, which has allowed this outbreak that we're currently having. And remember last year or the year before, when we had the polio outbreak, and again, this was local to London. So these are really quite scary, and this is why we need to think about vaccination as a whole, and not just the one or two that we talk about in context. So it wouldn't, I'm seeing sort of very quickly into personalised care. So I've spent quite a bit of time talking about the vaccine, the patient, the eligibility criteria, why people should have it, why we want people to have it. But really the time has come where, and we realise, you know, the benefit of personalised care, as to when we really need to start thinking about personalised care for these individuals, particularly if they are a bit vaccine hesitant. So we want people to we want to think of the person and not just as the patient. As I was talking about, these are the criteria. We want to think about the patient, the person that is in front of us, that person as a whole. And so personalised care is that partnership, okay, to develop a plan of care to what is relevant and specific to their needs. And sorry, I've forgotten the D in that top one. And it is about helping to make the patient or the person in front of us to come up with what matters to them, to listen to what matters to them. And it is really about giving them that opportunity. And for so long, we've thought about the numbers and the percentage and what our uptake is, but it's time to start thinking about, you know, what it is, vaccination and that personalised care agenda that is becoming so important to so many people, and particularly in our area. And it wouldn't be right to talk about personalised care and not to include this diagram, which talks about all the different facets of personalised care. And you can see from just thinking about vaccination, how many of those that it will sit into, how many of those areas that thinking about vaccination in a personalised care context will sit in there with the patient at the centre, thinking what matters to them. And so our conversations are really about making them understand, but helping them to understand that we are actually thinking about them as an individual, and we want this to matter to them because it is the benefit that they will get from having it. So when we've thought about the personalised care for those individuals, we then need to think about our own community and what get rid of this. We need to think about our own community and what our particular needs are. So here is our BHR. So I've said our BHR because we're talking about across the 3 boroughs, and what issues that might be particular to us here that we need to think about in the context of our local areas. So one of the things that we know, we talk about a lot now, are health inequalities. And we know, and I'm not going to read this clip here, you can have a read of it yourself. And this has just been completely lifted from the joint needs analysis of assessment, sorry, of a couple of years ago. So it's talking about, you know, we've done well in our local population and we've improved things steadily for a while, but actually it's stopped a little bit now, and there are still significant groups that are marred by ill health. And we've got marked inequalities that we need to consider and think about, and also that there are some conditions that are causing premature mortality that are different to those ill health and those other conditions that we're talking about. So quite a melting pot really of things that are going on in our area that we really do need to think about, and to think about how we can do our best by these. We also know, and this is a well-known fact that's been sort of trotted out. In fact, it's been around so long that I've forgotten actually where it originally came from. But we know that traveling from east to west, as you come out of London, sorry, from west to east, as you come out along the district line, that you lose 1 year of life expectancy with each station that you come out along. So we know we're out here at this east end, and so we really do need to consider the patient needs and those health inequalities. And this isn't the discussion all the time. It is really me thinking that we need to, and to alert you that we need to think about this in the context of vaccination as well, and how we can do what we can do with all of that information. So we're talking about vaccine hesitancy. We know that for anyone working in primary care, that flu season is very busy. It starts off with, you know, queues of people around, and we have very successful campaigns at the beginning. It's those stragglers. It's those people that, for whatever reason, don't prioritize it when, despite our efforts at asking them to come along. And here is, you know, what this is the definition basically of vaccine hesitancy. And what we need to understand, it's complex. We know that. It varies around different things, but what we know is that it's influenced by factors such as complacency, convenience, and confidence. And these are the things that we may be able to do something about, and that we're going to sort of think about what we can do. One of the issues, I think, is that when you talk about vaccine hesitancy, it is very much the onus is on the other person. We see vaccine hesitancy as they don't want it. And it doesn't make you think about a solution. Whereas if you turn it around and think, I've got low uptake, you know, you're working in primary care, and it's why are we only at X%? It just makes you think slightly differently. It's more of a problem-solving approach. So we need to think about that. Why is my uptake low? Uptake poor? Why is my uptake low? And then we can start looking at those questions. You know, what is it? Is it an issue around confidence in the vaccine or the provider? Are we looking at complacency? People just don't see or value the need for it. And we've talked about that a lot, about you know, younger people who don't really see, I'm never ill, I don't need it. And then we also need to think about the convenience, and particularly when we're talking about our area across BHR, and we're talking about health inequalities, then access and convenience and availability of, you know, getting appointments, getting to places is really, really important. And so we are just becoming much better, I would say, at thinking about all of these things and becoming a little bit more creative. So, but really, when we're looking at a list of people that haven't come in, rather than they haven't come in, just that question about why, I wonder why. And then who do we look to solve that? Who do we need to start thinking about? So one of the best ways, and again with our IT systems, is to identify that group of people, that list of people. And then traditionally, this would have been done in primary care, because we've been doing the vaccination, the flu vaccination for so many years. But really, after the success of our personalised care teams and their involvement with, particularly with COVID vaccination, then we know that that's a very important factor and a very important group that can help us to identify with, and particularly where they have relationships with some of these people, it may well be that, you know, they are already seeking help or having help in other ways, and that they're known to the team. So we'd be looking to them or anyone else in primary care to identify those barriers as to why those people may not be coming in. And I'm sure you'll all have, you know, lots of them. And there are some very simple ones. You know, people will say, actually, I'm you know, I can't bear needles. I've got a needle phobia. And it may be that, you know, that's something that we'll be able to do with them. and help them with. It could well be, you know, around the financial stuff. It's too difficult, you know, working mum with a number of children and all the things that we know that people struggle with around taking time off to come to the clinic to have their children vaccinated. So there's some fantastic initiatives that are going on across all our boroughs at the moment. And we know access is a big thing and it's being addressed in general practice, but there are also various pop-up clinics and some wonderful examples of excellent pieces of work around you know, getting, attracting that served population and trying to engage with them in sort of, you know, town centres and pop-up clinics and things like that. So it is really about, like I said, thinking, turning it around, thinking about why is it low and what can we do about it to improve things for that cohort. So that low uptake, again, this is just a more sort of academic way of saying it, is where we're looking at the root of the problem as to, you know, why this is an issue, and we're considering it in the context in our community of health inequalities and improving those health outcomes in the people from disadvantaged communities. So I've talked about the personalised care team and how important it is. And many of you will have been doing this, like I said, through COVID, but there's just something about if you're supporting, what we really want to do is to find out what they feel about the vaccine. So just ways of exploring their concerns and identifying where they've got their information from and what it is we can do to help. Some top tips here as to which, again, I'm not going to read out, as to how and why, if we were talking to somebody that we might want to consider doing with them. And I think the bottom one, planting the seed. People often like information. If they continue to be hesitant, then they just need some time to reflect and decide. And you see that with the flu, they don't have it 1 year and then sometime they'll come back. So I'll leave this to here for a second, just so that you can work through. You don't need me to read through any of these and keep talking. And I'll take a deep breath. So there we go. So we know that a lot of people will get their information from the media and from social media. So we need to be mindful of that when we're asking about where their information is from. Again, I've got a typo, friend or foe is what I'm saying. I think in most cases it's foe, certainly around the groups at the top. We want to be encouraging people to look at reputable sites, decent resources that are going to be able to help them to have an informed decision. So it's not all bad. Like I said, there may well be some places that, you know, that are socially responsible and they take that very easily. And then there are some, I think there's David Green, did some work with Mumsnet, and this was around the MMR and debunking the issues around MMR. So we can use it to our advantage sometimes, but often you'll find what people are showing you that they've been concerned about isn't necessarily thing that you would direct them to. So be aware of some good ones if you're having a conversation with someone, that you could then point them to something that is, again, social media, but is a more positive factor in vaccination rather than some of their negative ones. So this moving the needle, which was the a piece of work that was done a couple of years ago, it's very much around children, because we've been talking about vaccine hesitancy even before COVID in children. So people are more likely to see a negative message on social media than they were to see a positive. And when they looked at the number of parents, they said often are sometimes exposed to negative stuff. So we know it's out there. We just need to be aware of it and have something to counter if we're coming across and having that conversation. Again, it's not all bad. The role of the healthcare professional is very much trusted in the research that's been done, where we talk about all the factors around vaccine decision-making. And what came out was that there is a lot of trust in healthcare professionals when we talk about vaccine. We are considered to be a font of knowledge when it comes to it. And so all those interactions are really quite important to make sure that we say the right thing, we do the right thing, and we consider people's choice when we're talking about vaccine. And then there are some local issues that, again, may need to be addressed. And we've picked those up a little bit about pop-up clinics and things like that. So this was the Cochrane review in 2017 that said the professional, I've gone back to that, the professional are trusted. We are an important source of information for them. And this has really helped with, again, some of the IT and the technology around our computer systems, where we're able to send florries and text messages and information leaflets to people that may need them. They often don't know which non-health professionals to trust. So, and this was a survey that basically was telling us that the social media ranks the bottom of the table when it came to who to trust. The other thing that came out is people want clear answers and open discussions. So they don't want to be talked to, they want to have a discussion, and they don't want to be rushed. So often we will say, oh yeah, you know, I can do this, but actually they want time to make a decision. So this is important evidence in a Cochrane review that basically helps us to know how to treat people. And 93%, again, this is a different one of parental attitudes, Public Health England, 93% agreed that the healthcare professional remains the most trusted source of information. So we know we're doing a good job. We know there's evidence out there to say that people do trust us. So it is about making sure that we have enough opportunities, and we use all opportunities to have those conversations and to allow people to trust us when we're talking about vaccination, whether it's in the context of long-term conditions or MMR, like I talked about, or any other. The message is the same. People want an opportunity to discuss, they want information, and they don't want to be rushed. So promoting vaccine principles, the key principle is the same. This is what I've just said. We're going to recommend it. We know it's safe. Opportunity for communication at every contact, I suppose. We know that people trust us around, and we're offering empathy and understanding around them needing some time to make a decision. Put yourself in their shoes. If something was new, how quickly would you want to take it on? How quickly would you want to, are you an early adopter, or would you want to see how things are going on? So we're treating them as individuals, not as a cohort of patients. We're treating them as individuals and as people that have questions like ourselves. And again, this is another piece of research that was done a while back around attitude to immunisation in children. So the do's and don'ts of a vaccine consultation, and we can go through, you can have a read through this, and it basically summarises what people have said and what they would want to do. So we're going to explore concerns, we're asking open questions, we're understanding of their concerns, we're focusing on the facts, and then you're going to summarise that interaction as to what went on. What we don't want to do, what we want to avoid, is apportioning blame. And I think this was, you know, you should do this, you must do this. And certainly in the context of children, if they become unwell or develop an illness afterwards. So most patients are wanting, they want the best for themselves, they want the best for their children. And we know that. We just want to support them into making that decision, making sure that they have all the information, that they have the best information, and that they're happy to come to whatever informed decision that they're going to make. In a consultation, avoid repeating the myths. So if somebody says it, you just don't want to repeat it, because in a strange way, it can reaffirm what they've said if you're saying it. So you want to avoid mentioning it at all. You'll talk about something else, you may address it, but you won't use those exact words. Being directive is not, people are coming for a discussion, they're coming for an open discussion, they don't want to be told what to do. It's easy to spiral into being argumentative because of some of the thoughts and the ideas and the messages that are coming across in social media. It's easy to be dismissive or argumentative, for want of a better word, but it really doesn't help with the agenda. It doesn't help with the relationship, and it doesn't leave the door open. You're just seen as being obstructive and telling people what to do. Overloading with information, the same thing. They don't need loads and loads of information. They just want to have a discussion, a bit of information, maybe be pointed to some resources that they'll be able to have a read of and come to their own, and they don't want to be rushed. So be ready to give it, but it isn't, come on, yeah, you need to be rushed. So many of the questions that people ask are predictable, so you will be able to make your own resource pack or have something on your computer. This is a few of the things that I know there's something in there about MMR, but some of the vaccines, there are common themes really about them. I've picked out one here, which is the thing around, for example, around natural infection is better than immunisation. That's a myth or a comment that people will actually say to you, oh, I prefer to get it naturally. And that's okay. We know that natural infection can produce a stronger immune response for some things, but actually for others, it doesn't give any immunity at all. So if you look at tetanus, having tetanus doesn't give you any immunity at all. So you can't really pick and choose. Always remember that natural immunity is also, it means you have to have the disease and you have to survive the disease. So you're at risk of getting the complications of the infection that we were talking about. And we talked about this earlier. That's why we're trying to reduce that. So it is a bit of a risk. It's possible, but it is a risk. And there will be a few people that will say, my friend got this, was really well, and my friend got this and was really unwell. So you don't know which of those you're going to be. One of the things that some of the researchers told us is that if you're talking to an individual and they are more concerned about the consequences of the disease, so that is if we go back to, getting pneumonia, getting meningitis, getting sepsis and dying, if those are their concerns, so the consequences of the disease, they are more likely to then convert and have the vaccine. But if an individual is more focused on the adverse events of the vaccine associated with the vaccine, then they're less likely to vaccinate. It's just a little tip really, so that when you are talking to someone, you may be able to focus what it is that you're going to say, or your information that's going to help them along the way. Now, for that, going back, sorry, to that, the natural infection is better. When we're talking about some infections do not give any immunity, and we're in the context of MMR, obviously the measles complication is huge, and that's really what we're trying to avoid. So it might be a good one as an example to say that we wouldn't want people to have to get their immunity through a natural infection. We're really trying to avoid that because of the consequences of the measles complications. It didn't seem right to go through and not talk about vaccine storage, but I'm very conscious of time and we haven't got very much information. It would be nice to pick up any questions. So I'll go through this very quickly. For most of you, you know we have to have a validated fridge. It needs to be kept in range from 2 to 8. Don't over order, because if you over order, your fridge is over full. If your fridge is more than 50% full, it is likely to, there isn't enough air circulating. And so therefore you can end up with frozen vaccine. And the whole idea of the fridge is to maintain it, the quality from the time of the manufacture until the point of administration. So anything you do that is going to affect that is going to have an impact on the vaccination. And what's the point in giving anyone a vaccine if it isn't in its tip-top condition? It needs to be checked to make sure that it's okay and that the cold chain is maintained. And that's again twice a day, and you record it on the monitoring chart. It's fine at the weekend if there's no one there, obviously, or if the fridge isn't being opened. But if it's been opened and closed, you would need to do it twice a day. These are very basic things that CQC will be checking up on, infection control will be interested in, and there's lots and lots of information out there. And there's probably a 30-page document on vaccine storage and vaccine breaches that is light reading for anyone should they need it. So the over ordering, like I said, you're just taking up stock. It may go out of date, you're increasing wastage and the cost of the disposal, and also leading to vaccine issues. The other thing is that if there is an outbreak, like we're talking about the MMR or the polio of last year, if your fridge is full, then you don't really have any space for anything else. The main thing, and the one area that where vaccine breaches are the most common area, is the delivery from the courier from the vaccine delivery and getting it into the fridge. So that needs to be done promptly. And I think most of us now will have, and have told anyone that is taking a delivery, is that you do not put that box out of your hand. It doesn't matter what's happening. You walk from reception into wherever the fridge is. Do not put the fridge down. Do not put the box down, because then you're more likely to forget. It isn't, you know, pens and paper clips. This is perishable vaccine that needs to be put away immediately. Data loggers, if you have them, use them, because they're great, especially if things go wrong. They will tell you how long, and then how long you've been out of range, and that will be very helpful then to identify what vaccines can be used or not. The 4 R's is what we talk about in the fridge. So you read the temperature, you record it, you reset the temperature, and then you react if it's outside of 2 to 8. And everyone should have somebody in the surgery, a lead, and who you would identify, and then you would go to them if it's outside of range. The health protection team, the contact is here for London if you need anything. This is probably more for the diseases category. I should have put on the medicines management team, who will also be able to help you if you have any breaches. I'll leave this here for a second. What have I done? What have I done, Yasmina? Have I not...
Did you want us to stop sharing?
Thank you.
Yeah. Thank you so much.
That was at the end of it. I can forward that slide. So
thank you.
Thank you very much for listening. That's taken a little bit longer than I anticipated, but happy to take any questions if there is anything now, either to unmute, or if you've got some. Yasmina.
There is one question that Rita Ogana put up early on the chat. Under eligibility criteria for pneumococcal vaccine for occupation risk individuals, which group of people fall in this category, please?
Rita, I don't know. I'd have to go and look at the green book. It would probably be laboratory workers, I think, but I'd have to go back to the green book for the eligibility on the thing. And I should have put that in there. That is your font of all knowledge. That's where you get your information. And for anyone on any of the WhatsApp groups that ask for advice, to be honest, the green book and the relevant chapter in the green book is the first place that I will go to. And many of you will know I go back and tell you the answer and say, I got this on chapter 4, page 20 of chapter 18. So that becomes your Bible.
Wonderful. Thank you. That's the only question on the chat. I don't know if anybody else has any more questions. Please feel free to let us know. Whilst you're thinking, in the chat, I'm going to put the link to the feedback survey. Just 10 seconds of your time. Not even, no? It's mostly multiple choice and you have to write your name and that's about it. If you could tell us what you thought, that would be wonderful, and you'll receive a certificate of attendance.
So the key take-home messages from me are, why do we vaccinate? Because it stops people from, or reduces the risk of people getting the vaccine and reduces the complications. And when we're thinking about low uptake or vaccine hesitancy, I don't actually like the title, the word, we need to ask the question, why? Why? What are the reasons? You know, is it any of our underserved population, you know, the social inequalities, the health inequalities? Is it, you know, confidence in the vaccine? It will just help to focus your conversation with people and to treat them individually. So that's my take-home message.
Thank you very much, Nora. Any more questions, anybody, please? Don't hesitate. Thank you very much for the messages. Thank you. Thank you for coming. Thank you, Diane.
Thank you. Thanks.
Thank you very much. I'm seeing lots of answers coming in. Please don't hesitate to answer the questions very quick. It would be very helpful for us to know. Thank you. Thank you, Claire. Thank you, Kerry. Right, I will stop recording.